Okay, welcome to a deep dive. This is where we take your stack of sources notes, articles, research, and really boil it down into the absolute key insights you need to be truly well-informed. Today, we're tackling some revision notes, specifically focused on postpartum hemorrhage, PTH, our mission. To unlock these notes, pull out the high-yield gold, and make this critical topic stick in your mind for revision. Think of this as your shortcut, to understanding the essentials of PPH. We're going to journey through what it is, why it happens, who's most at risk, what it looks and feels like, how we figure out what's going on, the crucial steps to manage it, potential outcomes, and the serious complications we want to avoid. Ready?
Let's unpack this. And it's so important, isn't it? In the clinical setting, knowing this stuff quickly, it's paramount.
Absolutely.
Being able to access and apply this info can make all the difference. So yeah, distilling these notes like this, incredibly valuable for anyone prepping for practice.
Exactly. Making sure that knowledge is right there, right when you need it. So, okay, basics first. What exactly are we talking about when we say postpartum hemorrhage?
Well, at its core, PPH is just excessive bleeding after childbirth. Pretty simple definition, but the notes give us a bit more precision with the definition and the timing.
Right.
It's typically defined as significant bleeding within 24 hours of delivery.
And the timing matters, doesn't it?
Yeah.
I see primary and secondary here.
Exactly. Primary PPH happens within that first 24-hour window, straight after delivery.
Okay.
Secondary PPH is later, so anything from 24 hours up to 6 weeks after the birth.
Why is that distinction important? Why do we need to know that?
Well, because the underlying causes are often different, you see. Primary PPH, that's usually linked to issues right at the time of delivery or immediately after.
Makes sense.
While secondary PPH, that tends to be related to problems developing a bit later. Think infection or maybe retained tissue.
Got it. Okay, that leads us nicely into the causes, the etiology. The notes list quite a few potential culprits here.
They do. We're talking about the uterus not contracting properly, that's atony, or tears in the birth canal, bits of placenta left behind, even issues with the mother's blood clotting.
Sounds like a lot to remember.
It can be, yeah. But luckily, the notes give us that fantastic mnemonic for the primary causes. You know the one.
Ah, yes, the memory tool, the 4 T's.
Yeah.
Let's dive into those because they are absolutely essential for revision, right?
Definitely. First up is tone. This is all about the uterus losing its tone, becoming atonic. So the uterus, it needs to contract really firmly after delivery to clamp down on the blood vessels where the placenta detached. If it stays sort of boggy and relaxed,
Golgi, right, not firm.
then the bleeding just continues. And the notes highlight this. Uterine atony is the single most common cause of PPH, number 1.
Okay. Tone the uterus is too relaxed. Most common.
Got it.
What's the second T?
Second T is trauma. This covers physical injuries during birth, so lacerations or tears, could be the cervix, vagina, or even a uterine rupture, which is, less common but very serious.
So tone is muscle, trauma is tears. Makes sense. Third T.
That's tissue. This means there's something left inside the uterus that shouldn't be there. Specifically, retained placental tissue or maybe large blood clots.
Oh.
If bits of placenta remain, the uterus just can't contract effectively around those blood vessels. It's similar to atony, in effect. And material notes, this is the second most common cause.
So most common is an atony. Second is retained tissue. Good distinction. And the final T.
Last one is thrombin. This refers to coagulopathy, basically, problems with the mother's blood clotting ability.
Right.
If the blood can't clot properly, bleeding just continues. This could be a pre-existing condition or maybe something that develops during pregnancy complications.
The 4 T's: tone, trauma, tissue, thrombin. Okay, that gives us a really solid framework for those primary causes.
Excellent. The notes also touch on the main causes of secondary PPH, the bleeding that happens later on.
Right, and the main culprits for secondary PPH are infection, particularly endometritis and retained products of conception, or RPOC.
Endometritis. Yeah, the material gives us some context there. Notes it's the most common cause of postnatal morbidity. So issues after birth, between day 2 and day 10, affect about 1–3% of spontaneous vaginal deliveries.
Day 2 to 10, most common morbidity. Those are useful markers to remember. And the notes list quite a few things that increase the risk of that infection developing. Seems like a long list.
It is, yeah, but think about anything that might introduce bacteria or just stress the tissue, High-risk factors include having a C-section, A long labor with lots of vaginal exams, maybe membranes ruptured early,
Okay.
manual removal of the placenta, or conditions like maternal anemia, basically factors increasing surgical risk or exposure time during delivery. Helps to group them.
That does help group them mentally.
Right.
So we know the causes, the 4Ts, and secondary causes like infection. Who is actually at risk of experiencing PPH in the first place? Are there red flags we should be looking for before it happens?
Absolutely. The notes list several factors that make someone more susceptible. A history of PPH in a previous pregnancy, that's a major predictor. Huge red flag.
Right. Past history is key.
Others include conditions like preeclampsia, having lots of amniotic fluid that's polyhydramnios, delivering a very large baby, macrosomia, or needing an emergency C-section.
Why prolonged labor?
Well, prolonged labor can also increase risk, likely just by tiring out the uterine muscle, making it less effective at contracting afterwards.
So previous problems, conditions affecting uterine size or tone, difficult labors.
Yeah.
Common themes there.
Precisely. And the notes even mention things like placenta previa, where the placenta is low-lying. That can make it harder for the uterus to contract effectively in that specific area after the placenta detaches.
Okay, so we have the causes. Who's more likely to get it? At a really fundamental level, how does PPH actually work? What's the pathophysiology?
So the pathophysiology, as the notes describe it, it basically boils down to a few things. The bleeding happens because those uterine muscle fibers fail to clamp down on the blood vessels after the placenta is delivered. That's your atony, the tone issue.
Right.
Or there's direct injury to the blood vessels from tears. That's trauma. Or the body's ability to form a stable clot is impaired. That's thrombin. Or, sometimes a combination.
And the result is just uncontrolled bleeding.
Exactly. And the specific mechanism at play is directly linked back to whichever of those 4 Ts is the primary cause in that particular situation. It all connects.
That makes sense. So when you have a patient bleeding heavily after birth, okay, PPH is likely, especially atony, but what else should be on your radar? What are the differential diagnoses mentioned?
Good question. The notes list the key things you must consider that could mimic or contribute to PPH, and they align nicely with the 4 Ts, which helps you sort of check through the possibilities mentally.
Andy.
Yeah, so you need to think about retained placenta or clots, that's your tissue, any hidden genital tract lacerations trauma, uterine inversion, which is rare but a really serious type of trauma, and underlying clotting disorders, thrombin.
It's good how that 4 Ts framework helps structure the differentials too. Keeps it organized. Let's talk numbers. How common is this? What's the epidemiology say, particularly in the UK, where these notes seem to be from?
Right. The material states that PPH affects around 5% of deliveries in the UK, so not insignificant.
1 in 20.
Yeah. And the exact number can vary, depends on things like mode of delivery. C-sections carry a higher risk and the individual mother's risk profile.
And what about severe PPH? The really dangerous kind.
Severe PPH, yeah, typically defined as blood loss over 1,000 milliliters or life-threatening. That occurs in a smaller but still significant number, somewhere between, say, 0.3% and 1.86% of deliveries. There's some regional variation. It's less common than general PPH, obviously, but far more critical.
The notes mentioned something really important about maternal mortality related to PPH too, didn't they?
Yes, and it's actually a positive trend, reflecting improvements in care. Obstetric hemorrhage is no longer a major leading cause of maternal death in the UK, which is great news.
It is good news.
That said, it can still happen. It hasn't been eliminated. The notes mention, I think, 14 maternal deaths linked to obstetric hemorrhage in the UK and Ireland between 2016 and 2018. So while progress has been made, the potential for tragic outcomes is still there. It underscores how serious this condition is.
Absolutely. Okay, let's shift to the clinical picture. If someone is experiencing PPH, what would you actually see? Or what might they be telling you? What are the signs and symptoms?
Well, the most obvious sign is excessive vaginal bleeding. The notes give a useful practical guide here, soaking more than 1 sanitary pad per hour. That's a good rule of thumb.
Okay, pad soaking.
You might also see large blood clots being passed. That's another visual clue.
And what about the patient themselves, their vital signs or general condition?
Right. As the blood loss continues, they'll likely show signs of hypovolemia, low blood volume. So think dropping blood pressure, hypotension, a rising heart rate, tachycardia as the body tries to compensate. They might look pale, feel dizzy, and in severe cases show classic signs of shock. These are absolutely critical red flags. You need to spot them immediately.
Okay, so beyond those immediate signs, what sort of things would you specifically ask about in their history, according to these notes?
You'd want details about their labor and delivery. Was it prolonged? Was the third stage difficult? Was the placenta removed manually? Did the placenta look, I don't know, ragged or abnormal?
Yeah.
You'd also ask about symptoms that might suggest a developing secondary PPH issue. Things like fever, abdominal pain, maybe offensive smelling lochia or abnormal discharge later on. And crucially, ask if they've had PPH before. History is key.
Always ask about previous PPH. And on physical examination. What might you find that points you toward PPH or maybe its specific cause?
You'd check for signs of infection like fever or rigors. You'd confirm that tachycardia you might already suspect from the vitals. Any tenderness around the pelvis could point to infection or trauma. And crucially, you examine the uterus. Feel the fundus, the top of the uterus.
Right.
If it feels high or boggy, like soft and not well contracted.
That boggy feeling again.
Yeah, especially after you palpate it, that strongly suggests atony, the tone issue, or possibly retained tissue, the tissue issue.
Boggy fundus, classic sign to connect with tone or tissue.
Right. So you've assessed the patient, you suspect PPH, you've got clues from history and exam. What investigations do you need to order, like stat?
Yeah, the notes emphasize getting the essential blood tests straight away. You absolutely need a hemoglobin level and FBC to estimate the blood loss. You need clotting studies to check for those thrombin issues.
Yeah.
And blood cultures if infection is on your differential diagnosis list.
Okay. FBC, clotting, cultures. Any other samples needed?
Yes, the notes mention getting a midstream urine sample, an MSU, and a high vaginal swab, including testing for gonorrhea and chlamydia, particularly if you're suspecting infection as a cause, especially for secondary PPH.
Right. What about imaging? Ultrasound. Is that helpful here? Ultrasound can be used if you suspect retained products of conception, the RPOC we mentioned. However, and the notes add a really important point here for revision. It can actually be quite tricky to distinguish between blood clot and actual retained placental tissue on the ultrasound images.
Ah, so it's not always clear-cut on the scan.
Exactly. But here's a high-yield memory tip from the material. If you can see a normal, thin endometrial stripe on ultrasound, then retained products are unlikely. That's a useful takeaway.
Okay, thin stripe means probably no RPOC.
Yeah. Also, critically, the notes state pretty clearly that ultrasound is not helpful for diagnosing endometritis, the infection.
Good specific points there about ultrasound's role and, importantly, its limitations.
Yeah.
All right, you've investigated, you've got a clearer picture, maybe still working on it. This is the critical stage management. What's the immediate action plan? What do you do?
Okay, the goal, as laid out in the notes, is urgent, coordinated action. You need to control the bleeding, stabilize the mother, and prevent those serious complications we talked about. It's all hands on deck.
And the key principles for managing PPH. How do the notes break that down?
They break it down really nicely, actually. First, communication. Hit the alarm, get the whole team involved, obstetrics, anesthetics, senior staff, blood bank, porters, everyone needed. Call for help early.
Communication first. Makes sense.
Second, resuscitation. This means getting large bore IV access immediately. 2 large cannulas. Give oxygen. And be ready for blood transfusion, get blood cross-match stat, stabilize the patient.
Okay, IVs, O2, blood ready.
Third, monitoring and investigation. Continuously track vital signs, pulse, BP, oxygen sats, urine output. Keep monitoring fluid balance. And repeat those blood tests, FBC, clotting. Keep investigating the cause.
Got it. Communication, resuscitation, monitoring. And
finally, arresting the bleeding. You have to find the cause using your 4Ts framework and stop it.
How do you actually go about stopping the bleeding? What do the notes say?
Well, it involves various steps, depending on the cause you identify. Initial steps might include uterine massage, rubbing the fundus to encourage contraction, and giving uterotonic medications like oxytocin or ergometrine. Those help the uterus contract.
Okay, massage, drugs.
Yeah.
What if that's not enough?
Right. If bleeding persists, you move to more advanced interventions pretty quickly. The notes mention options like intrauterine balloon tamponade. That's often a first surgical line for atony if drugs aren't working.
A balloon inside the uterus.
Yeah, it puts pressure on the bleeding points. Other surgical techniques include the B-Lynch suture, which is like putting stitches around the uterus to compress it, arterial ligation, tying off blood vessels, or embolization procedures done by radiology.
Oh, wow, quite a few options.
And in severe, uncontrolled cases, especially if there are complications like placenta accreta, where the placenta grows into the uterine wall, or uterine rupture. Sometimes a hysterectomy, removing the uterus, is the final life-saving step.
It really highlights the rapid escalation needed in those severe cases. What about managing secondary PPH? That happens later, right? The approach must be slightly different.
Yeah, exactly. Secondary PPH management focuses more on identifying and treating that specific underlying cause, often infection or retained products.
So what do you do?
Well, if you suspect endometritis or infection leading to sepsis, it's an urgent hospital referral. IV antibiotics are crucial. You might do a speculum exam to rule out other sources of bleeding, like a hidden tear, or remove clots. If retained products are the cause, the notes suggest considering elective curettage, that surgical removal of the tissue often done with antibiotic cover.
Okay.
And importantly, throughout recovery from any significant PPH, primary or secondary, addressing the resulting anemia with iron supplementation is really key.
That covers the management pathways clearly. Okay, so if all these steps are taken promptly, effectively, what's the general outcome? What's the prognosis?
Well, the prognosis really depends on how severe the bleeding was, what caused it, and crucially, the speed and appropriateness of the management. That's the key takeaway.
Speed matters.
Absolutely. With rapid and effective treatment, most women recover well. They really do.
But delay can be critical, I imagine.
Hugely critical. Delayed or inadequate management can lead to severe complications and, tragically, maternal death, as those statistics we mentioned earlier showed. Time is of the essence.
Which brings us neatly to prevention. How can we try to avoid this critical situation in the first place? Because prevention is always better, right?
Absolutely. And prevention is a major focus in modern obstetric care. The notes highlight active management of the third stage of labor. That's the period right after the baby is born until the placenta is delivered. Using active management significantly reduces the risk of PPH.
What does active management actually involve?
A key part is giving prophylactic oxytocics medication like oxytocin right after the baby is delivered, usually as the shoulder is born or immediately after. And the notes give a powerful stat here. This simple step can decrease the risk of PPH by about 60%.
60%. Just from managing that third stage actively and giving a simple medication?
Yeah.
That's huge.
It really is massive. Oxytocin is generally the preferred drug for routine prevention after vaginal births. It's standard practice in many places.
Incredible impact.
It truly is. The notes also mention identifying women who have known risk factors before labor even begins and planning their delivery in a hospital setting that's fully equipped to handle potential complications, just in case.
So prevention isn't just a nice idea. It's a concrete set of actions with proven efficacy. Okay, finally, let's just cover the potential serious outcomes if PPH is severe or not controlled effectively. What are the major complications listed in the notes?
Yeah, the list really underscores the severity. We're talking about severe anemia, often needing blood transfusions, and the risks that come with that, like transfusion reactions. Systemic infection or sepsis is a big risk.
Okay.
Also, life-threatening clotting disorders like disseminated intravascular coagulation or DIC. There can be long-term issues from the surgical interventions needed. Organ failure is possible, acute kidney injury, liver failure due to the hypovolemic shock, severe respiratory problems like ARDS, acute respiratory distress syndrome.
Wow.
And as we noted, in the worst cases, it can unfortunately still lead to death.
That's a really stark reminder of why being prepared, recognizing the signs, and acting fast is so incredibly vital.
Absolutely. Vigilance and having a well-rehearsed team response are just essential when managing PPH. It's a team effort.
So there you have it. We've taken those MSRA revision notes on postpartum hemorrhage and done a full deep dive. We've pulled out the key definitions, that crucial 4 T's mnemonic for causes, identified who's at risk, understood the clinical picture, know which investigations to order, broken down the management strategy step by step, and recognized the vital importance of prevention and the potential complications. Phew.
Yeah, I think the core takeaways really are mastering that 4 T's framework: tone, trauma, tissue, thrombin. Being quick to spot the signs of bleeding and hypovolemia, and knowing those immediate steps needed for coordinated management, communication, resuscitation, monitoring, arresting the bleed. And remember that 60% reduction figure for prevention, it just highlights where we can make a real tangible impact.
It really does. And, thinking about that 60% reduction in risk from relatively simple prevention strategies like active management and prophylactic oxytocics, it does make you ponder the potential global health implications, doesn't it? If widespread, consistent implementation of those measures could slash severe PPH risk by that much. I mean, how drastically could it shift the epidemiology of maternal morbidity and mortality, especially in resource-limited settings around the world? It's quite a powerful thought, the reach of these core principles.
It really is. A lot to think about there.
Well, thanks for joining us for this deep dive into the notes on postpartum hemorrhage. We really hope this helps solidify this critical knowledge for your revision. If you are preparing for exams like the MSRA and found this useful, you might want to check out more resources like this over at passimsarray.com.
And freemsra.com, too.
Yes, and freemsarray.com. Great resources there. Okay, that's all for this deep dive. Catch you on the next one.